Today is the 3rd of May. It is AMAZE Brain Health Group's May meeting. We are based in Lafayette, Louisiana. We call ourselves a brain health group because we focus on the health of our brains versus the injury that we already had in a lot of cases. You don't have to have a brain injury to come. You don't have to have a brain injury to join. Just be interested in having a better brain is all. We bring guest speakers on a monthly basis, first Tuesday of the month, and transitioning to Kali Picard. She is also here. She's a speech language pathologist that does something different with her acumen. So Kali, I hand the mic over to you. Thanks for coming.
All right, great. I'm going to go ahead and share the screen because I have a presentation prepared.
Got it. Oh,
let's see.
There is a way to do that. Let's see. Share screen.
Let's see. It says host disabled attendee screen sharing.
Yep. Hang on.
Okay.
Content from a second camera.
I think if you pull up participants. Oh, look.
Did I do that right? I know it's just me.
I think if you pull up participants and then click on Kali's name, it might give you the option to let her share her screen.
I'm going to turn her over as the host. Da-da-da-da-da.
Or yes, turn her over as the host. That's the trick. Yes.
That works. All right. Well, I'm going to go ahead. This will stop others. Okay. Continue. Okay. So I'm going to do this one. Bear with me. All right. Play from start. All right. So I'm going to talk about dysphagia. And this is going to be an overview of swallow disorders as it relates to structure and function. And I'm going to kind of get into more of what structure and function means throughout this presentation. So I have some learning objectives for us. I'm going to do a little introduction and kind of tell you a little bit about myself. And then I may ask a few questions about y'all. We'll look at what a normal swallow is. We'll talk about the stages of the swallow, types of swallows. I'll define what dysphagia is, the importance of medical history, signs and symptoms, neurogenic deficits related to dysphagia, traumatic brain injury and dysphagia. I know this is a lot, and I'm going to break it all down. Structural causes of dysphagia, steps in diagnosing dysphagia, overall overview of exercises and compensatory strategies, diet levels, and questions.
Awesome.
So, as you know, Paul introduced me earlier, my name is Kali Picard. I'm a speech language pathologist, and I have 2 children, Amelie and Jean-Luc, and I am married to my amazing husband, Jean-Paul. And for fun, I like to paint. I graduated from the University of Louisiana at Lafayette with my master's in speech language pathology, and I've worked in a variety of settings, such as nursing homes to private practice, and I'm currently doing mobile modified barium swallow studies, and I'm trained by the team at Diagnostics. And I'll get into what a modified barium swallow study is in just a minute. But before I do that, let's see. I want to know about y'all. So are you patients? Have you had some sort of traumatic brain injury, medical professional, family, students? What is your association to the AMAZE Brain Group?
I can speak for most everyone here. You've got 2 survivors, survivor mom, another survivor, me. I had my brain injury through a choking incident. So I have first person interest here.
Okay, perfect. This kind of helps me tailor my presentation, so I appreciate that. All right. So, oops, I didn't mean to press play already. This is what a normal swallow looks like. I have a video of it. I want you to keep your eye on this black blob right here. That's what we call a bolus, which is which is just a fancy term for liquid or food. So it's going to enter, so it entered the person's mouth, and you're going to see all the muscles just working succinctly, allowing the food to go straight to the esophagus. So it went quick. And I'm going to play it again for y'all, just so you can really look at it. So you have the food and liquid went straight to the esophagus. This right here, oops. Just this right here is the airway, and this is where you don't want food and liquid to go. So now I have an exercise for y'all. I want you to place 2 fingers on the notch on your throat, and I want you to swallow. Did everyone swallow?
Yes.
What did you feel?
The lump went up and down.
All right, so that's exactly what that lump is, your larynx. And that's exactly what it's supposed to do during the swallow. It goes up and it goes out. And that way it protects your airway. It kind of acts as a V. So as you swallow, it closes up as it moves up and out. And there are 4 stages of the swallow. There's the pre-oral phase. So have you ever been to a restaurant and you're looking at the menu, and as you're reading and you're smelling the food around you, you start to salivate?
Yes.
That's exactly what that pre-oral phase is. It's preparing your mouth to break down the food, because the saliva has a huge role in breaking down food. The oral phase is whenever you have food or liquid in your mouth and you're preparing it to go to your throat.
Sorry, Callie, let me interrupt you. If you're the host, do you see somebody trying to join on your screen?
Let me open this up. I'm sorry. Let's see. I don't see anyone trying to. Usually I get a little message saying that they're trying to join.
Okay. She's going to regroup and come through the phone. Thank you for pausing. She'll be coming another way.
Okay. I'm sorry, I'm not super cool with that.
I am not either.
Right. So now we have the pharyngeal phase. So that's the term for your neck is called your pharynx. So whenever food and liquid go through the pharynx, it's being directed to your esophagus. And then of course the last phase is the esophageal phase, which can sometimes impact the safety of the swallow. And I'll go into that in a little more detail later on. All right, so there are 3 different types of swallows. You have your subconscious swallow, which occurs once every minute. And then you have, then you have your reflexive swallow. This swallow is your body's defense mechanism to protect the airway. So have you ever felt something go down the wrong way and you start to cough?
Yep.
Well, before that cough starts, the first line of defense is a repeat swallow to kind of push whatever's entering the airway out, squeezing it out. So that's where this comes into play. And then there's a volitional swallow. So whenever we are intentionally swallowing, and this is when we're either eating or cued to swallow, and it requires more cerebral involvement, whereas reflexive swallows just activate sensory motor regions of the brain.
Go ahead and check your allowance. She wants to come in using a phone. Sorry, go ahead. Since you're the host.
Oh, I see. Okay, I'm sorry. I think I just allowed her in.
You did. Thank you.
Okay.
Yeah, we're good.
Yeah, she's in.
Okay, cool.
Thank you.
All right, is this Rachel?
It is.
Hi, Rachel. Just to recap, I'm talking about swallowing disorders, and what I've done, and I'll just go back just a few slides and so I showed everyone what a normal swallow looks like through the video, and I'll play it for you. I want you to just pay attention to the black mass that's going to enter the person's mouth. So this is just an example of a normal swallow. And then we did an exercise where we felt what a swallow feels like from the outside. And there's a notch in the middle of your throat. If you put 2 fingers on it and swallow, you're going to feel it go up and down. We spoke about the stages of the swallow, and now I'm talking about the different types of the swallow, and I'm just wrapping that up.
Cool.
Now I'm going to go on and talk about dysphagia and what it is. So basically, whenever you have a problem with your swallow, it could happen at one of those stages of the swallow. So let's say it's happening at the oral stage. You may have food or liquid pocketed in your mouth. You may have food or liquid falling from your mouth. You may have trouble bringing food to your throat. Your tongue might be kind of weak. And so it may take you a lot longer to break down food than it normally would. If something's going on at the pharyngeal stage, you can have food or liquid stuck in your pharynx. You could have it go down the wrong pipe. There's different things that can go on there. Or if it's at the esophageal phase, then you could have food refluxed into your throat and going into your airway. Consequences of dysphagia include malnutrition and dehydration, aspiration, pneumonia, compromised general health, chronic lung disease, choking, and even death. Adults with dysphagia may also experience disinterest, reduced enjoyment, embarrassment, and/or isolation related to eating or drinking. Dysphagia may increase caregiver costs and burden and may require significant lifestyle alterations for the patient and the patient's family. Roughly 6.5 million Americans have issues with their swallow function. Of those 6.5 million, 13% to 14% of these patients are in acute care settings, 30 to 35% of these patients are in rehabilitation centers, and 40 to 50% of these patients are in nursing homes. This is something that I wanted to talk to y'all about is medical history. So let's say you have a therapist come work with you. Sometimes when it comes to sharing documentation from hospitals or from nursing homes, pieces of that puzzle go missing. And so having a conversation with your therapist or your doctor or whoever's treating you for the swallow, normally it's going to be the speech therapist, having this conversation really, really helps piece together the puzzle and helps us do better treatment. And I'm going to go through each question and explain why it's extremely helpful to share this information. So one of the questions is have you had a history of poor respiratory support? This could be secondary to COPD or any other pulmonary complication. So whenever you swallow on an inhale. Whenever you talk on an exhale. If you were to swallow on an exhale, then your airway would be wide open and food and liquid could go down the wrong way. So if you have any sort of discoordination with your breathing patterns, then this can impact the safety of your swallow. Also with COPD, the ability, oh yeah.
What is that? What is COPD?
So it is chronic, what does the O stand for? I can't remember what the O stands for. Pulmonary disorder. What was the O stand for?
Obstructive.
Obstructive. Thank you so much, Mary. Chronic obstructive pulmonary disorder. So
how would that manifest? Would that be kind of a choking, or that would be?
Yeah, absolutely. It'd be choking. So your airway would be wide open, allowing food and liquid to come in. I mean, not every person who has COPD has issues with their swallow, but they could have some complications there. Also, with patients with COPD, we also see decreased elevation of their larynx. And you know how I had you feel your larynx, how it raised up and down? That little notch. So if that notch isn't raising all the way, then that airway is not closing. So that's where there can be some issues there as well. So this respiratory support is really important to talk to your caregiver about. The next question that we have is, does the patient have a diagnosis of a neurogenic disorder? And I'm going to go into this in a little more detail, but often neurogenic disorders impact swallow function. Has my patient had any head trauma? So exactly what we're talking about, Paul, how you had your traumatic brain injury. There are several different areas of the brain that play a role in swallowing. And so any damage to the different parts of the brain can impact swallow function. So you have your frontal lobe, Broca's area 44, that sends messages to your motor strip, which is sandwiched between your frontal lobe and your parietal lobe. And your motor strip further relays those messages to the different areas of your body. And if there's some sort of miscommunication there, then there can be issues with the swallow. Also, your brainstem that also impacts, your automatic function. So those reflexive swallows, those can be impacted. Pretty much anywhere in the brain that plays a role with movement, if it has some sort of damage, then the swallow could be impacted. Not always, but it could be.
And we're talking from a concussion perspective. It's not necessarily flying out of a vehicle 100 feet. It's just conking your head, period.
Right.
Yeah. I mean, any sort of damage to any of the areas impacting movement or planning of movement can impact swallow function. Not always, but it can. So does the patient have a history of pneumonia? As I mentioned earlier, pneumonia is a repercussion of things going down the wrong way. So, and again, not just because you have pneumonia doesn't mean that you have a swallow disorder, but that could be, a subtle sign that something's going wrong. It's just good to know. Have you had cervical spine surgery? There are a lot of nerves that control the muscles that are related to the swallow function in your neck. And so if they get nicked during surgery, then that can impact swallow function. Do you have a pacemaker? This is extremely important for treatment. So there is a type of therapy called electrical stimulation, and that's where they put electrodes on your neck to help increase the neuromuscular contraction and create a stronger, more effective swallow. But if you have a pacemaker, the electricity could impact the way the pacemaker works, and that could be really dangerous for the patient. So that's a really good question that we want to know. Have you ever been intubated? For the same reason as the cervical spine surgery, there's a lot of nerves all throughout your throat that play a significant role in swallow function. And so if one of those is nicked, then that can cause some damage. Have you had a history of seizures? So this is twofold. One, it impacts our decision-making with treatment. So for the similar reasons as the pacemaker, we're not going to want to do electrical stimulation if you have seizures. But on the other side, whenever you have a seizure, that's a lot of trauma to your brain. So that can also impact swallow function if a seizure is significant enough to cause damage to any of those motor areas of the brain. Does the patient have a history of head and neck cancer? And have you ever received radiation to the mouth or neck? This kind of tells us a lot because radiation can do some pretty significant damage to the way the muscles move. A lot of times muscles become really thick and fibrous, and so they lose a lot of their motility. And whenever you don't have the muscles moving and contracting, then you don't have airway protection, and that can lead to some serious issues. Another question that we ask is, what are your teeth like? Do you have teeth? Do you wear dentures? Do the dentures fit properly? If you do have teeth, do you have most of your teeth? Because this impacts the oral stage. So how well you're able to break down food. If your dentures don't fit properly, it's probably pretty challenging to break down food. Or if you don't have all of your teeth or you don't have any teeth, and your tongue is not strong, then that can impact the way you break down food. I mean, I have seen patients with very strong tongues break down cookies without any teeth. So that doesn't necessarily,
Wow.
allow us to rule out, hey, you can have regular food or you can't, but it's just good information to have. And then another question that we ask is, have you had a history of a tracheostomy, or do you currently have a tracheostomy? And whenever you have a trach, it acts as a weight on your larynx. And if you don't have a really strong swallow, sometimes it doesn't allow your larynx to move properly. So I'm going to kind of compare it to having weights on your legs. Is it easier to lift your leg with a weight or without a weight? It's a lot easier to lift it without the weight. And so the same concept applies to having a tracheostomy. And then we also having a tracheostomy tells us that you have trouble breathing on your own. And that kind of circles back to that first question with the respiratory support. And that allows us to ask some questions like, are you able to wear a Passamere valve, which allows you to speak? It's a covering over the air hole that allows you to phonate. Or can you wear a cap completely? So have like a complete cap over it. And if you have a cap over the trach, then that means you're breathing through your nose rather than the trach. You're not relying on the trach. And so that tells us, okay, you're getting a lot stronger. You can handle your breath support a little bit better. All right, so overt signs and symptoms of aspiration. So this aspiration just means that food and liquid are going towards your lungs. So here are the things that we look at: coughing and choking, eye watering, and a wet vocal quality. So it's going to sound like you're gurgling during the meal. And these are just the obvious signs and symptoms. There are some more subtle signs. So runny nose, weight loss, pain during the swallow, globus sensation or feeling like something is stuck in your throat, fever, chest pains, vomiting, drop-in sats, which is basically, have you ever used a pulse ox and you put it on your finger and it gives you a percentage of your oxygen? Well, if that percentage of your oxygen drops during the meal, that kind of gives us reason to pause and say, hey, what's going on? Is there something going on with the swallow? What's happening? Pocketing, that just means food and liquid getting stuck in your mouth. Excessive drooling, increased oral transit times, and that's just a fancy term for it takes a long time for your tongue to propel food to your throat. And then again, pneumonia. And sometimes there are no signs and symptoms that things are going down the wrong way. It is completely silent. And that's whenever your body just doesn't sense it. Usually we'll see silent aspiration after a patient has had pneumonia several times in a row. So that's when we're like, we should probably check the swallow and see what's going on. They had pneumonia 4 times this month. That's whenever we kind of look at that. So neurogenic deficits linked to dysphagia. So we have stroke, dementia, which is an umbrella term for several different things like Alzheimer's, Parkinson's disease, primary progressive aphasia. There are several different types. You have frontal lobe dementia, but I kind of put dementia and Alzheimer's disease because oftentimes they're used interchangeably. Yeah. So I just sort of wanted that right there. Parkinson's disease, myasthenia gravis, multiple sclerosis, amyotrophic lateral sclerosis, developmental disabilities in an adult population, post-polio syndrome, Huntington's disease, and muscular dystrophy. I'm not gonna go through each one, but I did pick 3 to kind of talk about. So let's go ahead and talk about stroke. So what is a stroke? So basically, it is one of the most common and devastating clinical disorders that can affect any person. A stroke is characterized by a sudden and rapid development of clinical symptoms and signs due to focal or global loss of cerebral function that lasts more than 24 hours or leading to death. There are two types of strokes. So you have hemorrhagic stroke, and you can either have an intracerebral hemorrhage, which means the hemorrhage starts from inside the brain, or a subarachnoid hemorrhage, which means that the hemorrhage starts on the surface of the brain. You can have an ischemic stroke. And that's the most common type of stroke. And it's when the blood vessels supplying the brain becomes blocked or by a clot. And there are two types of ischemic strokes. You have thrombotic, which basically the blood clot forms in an artery leading to the brain, and embolic, which is whenever the clot forms elsewhere in the body, such as the heart or the neck, and breaks loose and travels to the brain. So dysphagia that is present immediately following a stroke is found to resolve in half of all patients, although some group of patients in whom dysphagia persists for more than 3 weeks are generally found to have less favorable outcomes. Patients with dysphagia have increased levels of disability, longer duration of hospital stay, and have a greater need for subsequent institutional care, as well as increased death rates. 65% of patients were reported to have a swallow disorder linked to their dysphagia. Normal brain. So now we're going to shift to a normal brain versus an Alzheimer's brain. So you can see with the normal brain, it's nice and full. With the Alzheimer's brain, it's pretty much wasting away, and you see a lot of atrophy. And with Alzheimer's disease, I kind of wanted to focus in on tips on how to improve eating during meals. And because a lot of the issues that we run into with swallowing is more related to the memory loss and kind of forgetting what they're doing. We can see some issues with the actual musculature, but most often the first thing that we do see is just the patients kind of forgetting what they're supposed to be doing. So we offer, so here are just some tips. So offering environmental cues to signal the change from a recreational activity to an eating activity. Increase lighting and contrast at the table setting. Use verbal cues and written reminders like, hey, you should probably come eat. Control noise, light glare, and odor. Serve individuals promptly after they are seated. That way they don't get distracted or forget why they're sitting at the table. Offer visual cues for boundaries by using placemats or square tables to reduce interest in another's meal.
Wow.
Decorate the dining room in a home-like manner to provide reassurance and environmental cues. Supervise the meal, cue and encourage eating, use one-step directives. So eat the eggs or pick up your fork. So just giving one command at a time and really simplifying it. Limit the number of utensils. Usually people will choose the utensils closest to their dominant hand. So maybe just have a fork or just have a spoon. Use cups with handles that are easy to grasp. Serving larger portions for breakfast may help to maintain weight. Increase the number of finger foods and provide foods on the go. Clients can often be tempted to eat by adding sweetener to foods. So as you get older, your ability to taste changes, and also it deteriorates as well. And one of the last things that most people are able to taste is sweet. And so that's why they recommend adding sweeteners. So it may seem odd that you're putting sugar in the mashed potatoes, but that does increase a patient's ability to want to eat it. Serve one item at a time to decrease distractions and limit choices. Provide ethnic or culturally appropriate foods. So you wouldn't serve someone from Minnesota a big thing of crawfish, They wouldn't know what to do. Alternate hot and cold, add sweetener, and alternate with spicy foods. Add ketchup, mustard, or salt and pepper if medically appropriate. So here's another thing that we kind of run into is sometimes these patients get really anxious about mealtime because they'd be worried that they have to pay. But, you know, when in reality, all of it's covered. And you could say that so many times, but just reassuring them that, you know, the food's paid for, or you can provide meal tickets or imitation money, or explain that it's included in the meal club, just something so that they're not so worried about
paying for it.
Yeah. Seat individuals according to compatibility rather than disabilities. So, you know, if they're sitting by someone that they like, then the meal usually goes a lot smoother. Offer liquids and water consistently throughout the day and place beverage stations in high traffic areas. So that'll just be a reminder for them to stay hydrated, just having that visual cue out and ready. They can grab the water and be like, all right, cool, we're good to go. Repeat redirection to the task of eating meals and snacks. So that kind of goes into having supervision during meals, just to kind of keep them on task. Do not use garnishes or decorations that are not easy to chew. Make small tables for 1 or 2 available for the residents who perform better when eating alone or in small groups. And again, that kind of goes into having decreased distractions. So now let's talk about Parkinson's disease. And this is what I've seen on the job, the impacts on swallow function. So I'll see that the tongue gets really weak, and I'll also see that it'll rock back and forth, bringing food to the front and the back before the swallow is actually triggered. I'll see a lot of premature loss. So that just means that food enters the throat before the throat has time to prepare for the swallow. I'll see decreased respiratory control, fatigue during meals. So the first few swallows might look good, but then by the 7th time that they try to swallow something, the swallow kind of breaks apart, and we see increased difficulty bringing food to the throat. We may see food and liquid going down the wrong way. We may see significant pharyngeal delays where the food just rests in the throat for 10 plus seconds. So we'll kind of see, you know, different things like that. And then we'll also see overall generalized weakness of pharyngeal musculature. So maybe the larynx isn't raising as high as it needs to shut and protect the airway.
Just on this, sorry, just to comment, some of these creep into concussion, traumatic brain injury folks. They just kind of creep in, but they're not substantiated enough to say you have Parkinson's, but it's Parkinson's-like or stroke-like, based on 1 week versus the next week, or 1 day versus 3 days later. Just wanted to add that.
No, that's great. I'm really glad that you mentioned that, because that makes me, well, I'll get into that later, but
Right, thank you.
Yeah, absolutely. All right, so every patient's different and may present differently. There's a wide range of dysphagia prevalence with Parkinson's disease from 11% to 100%. And this variation generally is dependent on the stage of the disease. Oropharyngeal dysphagia is a common symptom even early on in the disease process. Although most patients recover from their swallow dysfunction for short periods of time, swallow function degenerates with the disease progression. So you can have short-term success, but in the long run, because the disease is degenerative, you're going to start seeing problems again if you're not on it. So yeah. All right. So now we're going to talk about TBI and dysphagia. So as y'all know, traumatic brain injuries are a result from a bump or a blow to the head. And later on, you can have swelling of the brain or seizures, and it is treated by a doctor. But TBIs can cause speech, language, thinking, and swallowing problems. These problems can affect you in school, at work, and in everyday activities. And speech therapists are often the ones who are treating these issues. Did you know that at least 5.3 Americans live with a traumatic brain injury? That is 1 in every 60 people, and about every 9 seconds, someone in the US is sustaining a brain injury. Dysphagia is common with traumatic brain injuries, and in some studies have found that up to 93% of people have a traumatic brain injury and issues with their swallow.
Kudos, you actually got the numbers right. You get an extra big prize. Also, my first line of realizing of my brain injury was through a speech therapist. So speech therapists are, to me, angels walking on the earth. Go ahead.
Thanks.
You're welcome.
All right. So let's go through radiation in dysphagia. So as I mentioned before, radiation can cause the muscles to become a lot more fibrous, which reduces the overall mobility of the way that the muscles move. So if you've had a lot of radiation to your neck or to your mouth, they're not going to move very well. And this is anecdotal, but I was doing a swallow study on a man who had so much radiation that you have this structure called an epiglottis, and it kind of sticks out. Well, he had so much radiation that it turned that epiglottis into a nub. So instead of, I'm going to have to get a diagram to show y'all what I'm talking about, but, and I will in a little bit, but that just blew my mind. But anyways, radiation I feel like there's not a conversation about how it impacts swallow function before patients sign on to do it. There may be now, but a lot of times patients didn't realize how much it would impact their ability to eat and drink. They have started doing studies on what can be done prior to radiation. And what they've found is that recent research done on a small number of patients found that exercise programs during the treatment, before, during, and after the treatment, improve the quality of life and also improve some movement of those structures involved with the swallow, but they still need to keep doing testing. They need to keep doing more sample sizes, but this was just like one small study. So hopefully, that can impact patient swallowing, but yeah, radiation does a lot of damage to those muscles. Structural impacts on swallow function. So we talked about function, and function is, in a nutshell, the way the muscles are moving and interacting with the food and the liquid. And we talked about neurogenic disorders that had to deal with the function of the swallow. This is more structural impacts, things that just sort of developed in the person with the swallow disorder. So I'm just going to kind of briefly go over them. We have osteophytes, and I'll go into more detail in a little bit. Cricopharyngeal bar, Zinker's diverticulum, laryngoceles, and then an over-exaggerated lordotic curve. All that means is your neck, there's a natural curve to your neck. Imagine that curve being extreme, almost like a sideways U rather than a soft C. Wow. That's all we're kind of talking about, is that if it's curved so much, then it can cause food and liquid to be redirected into the airway rather than to the esophagus. Okay. Not always, but that happens that doesn't always happen, but it can happen with aging. And then inflammation of the pharynx, that can cause the pharynx to narrow quite a bit. And you see inflammation either with radiation, after having surgery, or having some sort of traumatic impact to the neck. So this is what an osteophyte looks like. It's just a bone spur that's sticking out. And sometimes it's not a big deal. And then sometimes if it's in the wrong location, then it can cause food and liquid to go into the airway. It also depends on size too. You can have some tiny osteophytes, you can have some bigger ones. And our first line of defense is to refer to an ENT because they're kind of the specialists on that side. The next is a Cricopharyngeal Bar. So this is the Cricopharyngeal Bar. Sometimes there's no impact on swallow function, and sometimes it causes food and liquid to reverse back into the pharynx and spill over into the open airway. It just depends. And then sometimes food and liquid can get stuck there. So sometimes we'll see like a pill get stuck.
Is that bone or is that just flesh?
It's flesh. It's just fiber. It's just some sort. It's like a growth kind of coming out. Yeah.
Okay.
And then this is called a Zinker's diverticulum. So it's just a sac that's developed right here. And sometimes they're not problematic. So if food and liquid naturally drain on their own, if the sac's small, it's not a big deal. But if it's big and food and liquid are getting caught here, what can happen is it'll start to reverse up into the throat, and it places the patient at significant risk for food and liquid spilling over into the open airway. Not to mention, if you're eating chunks of food and the chunks of food land in here, it could start to rot and cause infection. So our first line of defense with the Zinkers is to refer to a gastroenterologist. This is a laryngocele. It's just like a Zinkers. It's just a pocket where food and liquid could get caught. Sometimes it's not a big deal. Sometimes it is. It just sort of depends. And our first line of defense is ENT. So now let's talk about diagnosing dysphagia.
Isn't that a great picture?
had to throw that one in there. So you're going to want to get your MD so if you feel like you're having issues with your swallow, you want the MD to refer for a speech therapy assessment. And usually the speech therapist will come and sit by you while you eat your meal. And that's called a bedside swallow evaluation. From there, the speech therapist will recommend an instrumental assessment, either a modified barium swallow study or a fluoroendoscopic examination of the swallow. And so the modified barium swallow study is you're given barium to drink, and barium's also mixed with food. And you see this right here. This is called the C-arm. This is the x-ray. It does a video of the swallow. And we watch in real time as food and liquid travels through your throat down to your esophagus. The fees, that's whenever you stick a camera through your nose all the way down to your vocal folds. And whenever you eat and drink, the camera kind of records it from there. There's pros and cons to both. I'm more partial to the modifieds, but it's probably because that's where my area of training is. But both are good assessments to look at swallow function. From there, a plan of care can be formed based on the results from the modified barium swallow study or the fees, and either treatment or referral to a specialist is kind of formed. So let's say your recommended treatment. Sometimes that may result in using compensatory strategies. But just a disclaimer, imaging is required before employing any compensatory strategy. Everyone is different. Every swallow is different. Different things work for different people. So a strategy that they may recommend is called a chin tuck. And what that does is it reduces the distance your larynx has to travel to close. And so let's say you have a weak larynx, that might help close your airway off and allow you to eat safely. Small bites, sometimes you just need smaller food. Maybe your throat can't handle a larger portion. Fully breaking down food before you swallow, alternating liquids and solids. Maybe you're having a hard time getting food to leave your oral cavity. Sometimes a liquid wash to kind of wash it back can help. Head turn, we'll usually see this with using, you know how we talked about the osteophyte? Osteophytes are usually on one side. And so if you turn your head, that kind of widens and relaxes the UES, allowing more space for food and liquid to travel to the esophagus. So that's why we'll sometimes use a head turn. 3-second hold. This might give your throat more time to prepare for the food and liquid traveling down. Maybe you need to avoid mixed consistencies like gumbo or cereal, because having two different consistencies is a little too complex for your muscles to handle. Or an effortful swallow. This is whenever you swallow as hard as you can. And you know that whenever you're swallowing as hard as you can and squeezing all that food, that might help produce a more efficient swallow. We also use that as an exercise too.
For those who are not from Louisiana, gumbo can be substituted with the word soup. Go ahead.
Oh, thank you. Thank you. I'm sorry. I just assumed that.
Go ahead.
I'm really glad that you said that. So yeah, effortful swallow. So here's some exercises. So effortful swallow can also be an exercise. This next one, and again, before doing any exercises, you want to get the diagnostic work done first. You want to have imaging so that you know what to target. Masaka Maneuver. So I want everyone to bite the tip of your tongue, and while it's in between your teeth, I want you to swallow. Ow. Did everyone try that?
That's not easy to do.
It's weird. Yeah. It's weird to do.
So yeah, so that's one of the exercises. And it helps strengthen your tongue. It creates some resistance and it helps better propel food to your throat. Then we have the Mendelson Maneuver. And this is where you hold your larynx up. And you know how I talked about swallowing on an inhale? I want you to swallow, but instead of releasing your breath right away, I want you to hold your breath. And I found that kind of helps keep the larynx elevated. So swallow.
That's not easy.
Yep. So, and that helps strengthen your laryngeal musculature. E-stem, we kind of talked about that earlier. That's where you put the electrodes on your throat. And again, if you have seizures or if you have a pacemaker, you do not want to do this. Gliding E just sounds like this. E. And again, that helps raise your larynx and it works your laryngeal musculature. Sorry. And then you have,
so that you can hear me.
Then you have your velar sound, the g, 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 and that's the hard glottal attack, and that helps helps increase airway protection. Sometimes after having a swallow study, you'll be given a diet recommendation, and a regular diet is you just eat whatever you want. Then liquids, you can drink whatever you want. But sometimes, you know, they may restrict you and you may have to modify your diet to having soft regular. So fish instead of the pork chop. Or they may say, hey, you want to have mechanical soft consistency. So everything is chopped up real small. Minced consistencies, that's like ground meat. So you want to have everything ground. Or pureed, like mashed potatoes, you'd want to puree your meats, puree everything that you're given. just because you're on a mechanical soft diet doesn't mean that you can't have some of the things you love. So let's say you love Oreos, dip it in some milk. That'll soften the cookie and it'll make it a lot easier to chew and swallow. So there's different strategies that you can do there. For liquids, sometimes it's not safe to drink thin liquids. So nectar thick liquids is the second level of thickness, and it's about as thick as syrup. And you can get thickener powder from any pharmacy, or you can order it off Amazon. And also what I've seen on Amazon is they have the pre-thickened liquids, which make it a lot easier rather than having to measure everything out. You can have honey thick liquids. It's as thick as honey, or you can have pudding thick liquids. And usually we try to stay away from pudding thick. But if it's if it's the only thing keeping the patient from not getting a feeding tube, then that's what we're going to try to shoot for. So yeah. And just for fun, I figured I'd kind of show y'all some of my art.
Cool.
A little bit more. And then this is my family.
That's a very good depiction of your family.
And now questions.
All right. So at this point, go ahead and share back to me.
Okay.
Because this is the part where we do have questions and we do have open conversation. And this is the part where we go toward more of a personal basis. Thank you. This is more personal, so this is not included in the video. But thank you, Kali, for joining.
Yeah.
If you're following along with AMAZE Brain Health Group, our next meeting is on July 7th. You'll find it on our Facebook page, which is AMAZE Brain Health Group. And thank you again. And this is probably the better part of the whole shindig, which is us having a full open conversation about what we deal with individually, not to diminish what Kali just went through, because it was extremely informative. Thank you so much. And we hope to see you again. All right, everybody stay on.